that I'm going to start sharing my screen now. Get this thing started. Give me 1 second. Okay. Share screen and keynote. There we go. And play. So what I'm going to be speaking to you about, thanks for the introduction, Steve, and happy to do this conference series every year. Usually it's in person, which I always appreciate more than a webinar format, but we'll make do with what we got here. Steve, since I can't see the questions, or Tom, yeah, you guys are gonna have to pipe in and let me know if something comes up. I find these things to be always better if we can be more real-time interactive and still wait to the end and doing questions, because half the time you forget what we wanted to ask about if we wait to the end. So yeah, as Steve said, we work at UCSD in the medical center there as an emergency physician attending. Why am I talking to you about this? 2020 has been a hell of a year, folks. Been a lot of stuff going on, a lot of disasters, both real disasters and political disasters all around. First, got to say that my opinions and assertions here are really my own personal opinions, and they don't represent the official policies of the government of the US, required by law to say that, just keep me from getting in trouble with the people that I work for. I also do want to take this opportunity to give kudos and credit to a mentor of mine, Dr. Jake Jacoby. He is a team commander for CA4 DMAT, which I'll be talking to you a little bit about, who provided me a lot of background information so I didn't have to recreate the wheel regarding this talk. And there's Jake during one of our training exercises. So why am I talking to you about this and not somebody else? Well, because I have a little bit of experience in it, and it's an area that I have a lot of interest in. As a member of the DMAT CA4, which I'm going to tell you a little bit more about, I'm a medical officer, and with them I've done many training exercises as well as deploying to the Louis Armstrong Airport in New Orleans, right in the aftermath of Hurricane Katrina. Also, I deployed with the team called International Relief Teams, which is an NGO that does international relief work in the immediate aftermath of the Haitian earthquake in Port-au-Prince. And then just most recently, within the last 2 years, have become a medical team manager and specialist with the Urban Search and Rescue Task Force 8, which is based out of San Diego. So what I hope that you'll get out of this talk is not only a little bit of a sense of the structure that the United States uses to respond to disasters and how that whole thing works, but also maybe if you're interested, you'll sort of get an introduction of what you might be interested in doing and how to go about doing it. Remember, I mean, all disasters really are local. Nobody feels it more than the people that are involved in the immediate disaster. When it comes to fires, we all know that those who are displaced are the ones who feel it the worst. But then the people that respond are the local assets that are in the area. That's all going to be first responders that are local, whether you have local EMS agencies, fire, police, you have local urban search and rescue resources, hazmat, everybody like that. The hospitals, everybody steps up and starts to respond. The immediate command and control, that's also typically run locally. And there's various ways that ICS works. We're not going to get too much into ICS. I want you guys to stay awake. But it is, if you're interested in disaster response, it's something that you will have to learn about so you can function well within that environment. And it's not until that the local resources get exceeded that you start to go up the food chain a little bit. If you can't respond at the local level, then you go to your city level. Then if that's not enough, you go to the county, up to the state, and up to the federal government. If your needs can be met by your local county, that's as far as the disaster response will typically go. Doesn't mean that you won't get support from the federal government in terms of dollars, but in terms of response and resources to the immediate disaster, you're typically going to stop at the highest level that you need. Not every disaster gets the federal government response. How does the U.S. organize its response to disasters? It's organized in what they call the National Response Framework. There you can see that the most recent iteration, I believe 2008, you're going to want to go to that website listed there, FEMA.gov NRF, and that'll describe for you in exceedingly detailed depth how we respond. But in general, the response that's formed by the US government is broken down into what we call ESFs, or emergency support functions. The ones that really most of us who are medical are going to be concerned with are going to be ESF 8, which is Public Health and Medical Services, which the DMATs are going to be involved in, and then ESF 9, which is the USAR, which is all search and rescue. When you look at ESF 8, Emergency Support Function 8, it's broken down even further into things that we're going to be involved in, which would be medical care personnel, health surveillance, health, and even veterinarian equipment and supplies, and things that maybe we as medical personnel are not going to be directly involved with, things like vector control, behavioral health, food safety and security. All of the things that you can think that might apply to those two larger topic areas falls under the purview of ESF 8. Most of you, I would imagine, either work with first responder agencies or within a hospital. There's probably not a whole lot of people who work in private practice, but there may be some on this webinar. But if you do work in a hospital and you're interested in disaster response, you may want to take a look at what your hospital's disaster plan is. They are required by law to have one, and it's not only a good legal requirement to have, but it's good for them to have already thought these things through before they are actually needed. Now, it's not to say that they always go off without a hitch whenever these things happen, because nothing ever happens exactly as planned, but to have gone through it and have a plan together is important. You can take a look at what some of the things that are involved in a disaster plan. And a lot of the things may not apply to us as medical personnel per se, things like logistics and business recovery and those kinds of things, but absolutely we are impacted by things such as the command center, triage, decon, surge capacity, those kinds of things. But it involves all aspects of the hospital leadership and hospital care. Speaking about phases of disaster, really what things, we start with the preparedness phase. And many of you may think that that's too boring. You want to get dirty and do the real work that needs to be done. But a lot of the work that needs to be done is at the front end before the actual disaster happens, which is what we call the impact phase. That is then followed by response, which is the things that I've done most in, followed by recovery, which can last years, and then mitigation to prevent further problems down the road. Dr. Jacoby came up with a modification that there is the 6th phase of disasters, which is the finger pointing, which always happens after disaster. After the dust is settled, everybody points fingers. 9/11, everybody pointed fingers at each other to say who's responsible. After every disaster, once things have cooled down, or even many times inappropriately during the heat of the disaster, people start pointing of fingers at who is the one that's not doing what they need to be doing. And that is not always the most productive way for things to happen. Things that medical personnel need to be familiar with when it comes to disasters, there's lots of subject areas that you could spend, individual lectures, you could spend an hour on each of these. But some of the topics, if you're interested, are things such as the epidemiology, what disasters are primarily made of, how to perform a rapid assessment, search and rescue, multi-casualty incidents or surge management, and then triage, treatment, and alternate standards of care during disasters. While we all want to do the standard of care medicine during all times that we can, during disasters that simply may not be possible, and you are faced with ethical decisions about how to do the best you can with the limited resources that you have. Specific clinical situations that you may be asked to respond to and you need to learn about, things such as blast injury, crush, which a lot of times you'll see with earthquakes and structure collapse, hazmats, mass burn care, inhalational injuries. CBRN stands for chemical, biological, radiological, and nuclear and bioterrorism syndromes. That's something that has been a forefront of a lot of work that we've been doing with our responding agencies lately, unfortunately. Epidemics and pandemics, which we're in the middle of right now, and cemetery disasters. You say, what's a cemetery disaster? What the heck is that? Well, think about it. A lot of times when people are buried, they're buried in a grave, and sometimes the grave is not that deep. And during flood incidents, such as some of these pictures here following Hurricane Ike and flood in Louisiana, the caskets can become dislodged. And you think, well, what's the big deal about that? Well, it actually can be quite difficult to repatriate the remains to their appropriate place. Unfortunately, a lot of times the bodies are never identified, and so they can't be appropriately replaced into the area where they came from. There's entire specialties within the disaster response framework, teams such as DMORT, which are specifically made up of coroners and medical examiners that do the painstaking, laborious work of identifying human remains and trying to get them to the families and to the appropriate place. They're involved in not only cemetery disasters, but also the 9/11 incidents at the Twin Towers and the Pentagon, and any time where you have mass casualties of people. Other things that, for the medical professionals that might be listening, there's a lot of mental health aspects of disasters, mental health of the victims and the responders, and this whole concept of critical incident stress syndrome and peer debriefing. You may not feel like you've been stressed or have a mental health issue related to an emergency disaster response. Everybody feels something, and it's how you deal with it that prevents that becoming a pathological response. Hospital emergencies and disaster preparedness response, evacuation planning, and then volunteering in disasters. How do you actually do it? We're going to actually get into a little bit to that for you, so that if after this talk or you've been thinking about it, this will give you the information that you need to know to start getting involved, because we can never have too many appropriately trained and prepared disaster response professionals. What does epidemiology do? There are some of the things that they do. All of those are involved to varying degrees, depending on the disaster. And floods in particular, you'll get a lot of issues where there's epidemiology looking at the diseases that can come up when sanitation systems are overwhelmed. And they're involved intimately right now during the COVID pandemic. What kinds of disasters are there? The majority in the United States and worldwide, the majority of disasters are floods. Not only in the hurricane belt in the United States, but also in areas where you get heavy storms and the rivers surge, in places that don't have the best infrastructure, places where they are experiencing the monsoon or typhoons. Floods by far cause the majority of disasters. Windstorms about 15%, earthquakes and volcanoes 30%, and then others, what might be considered others you would ask, things such as a global pandemic, things such as a terrorist incident, things such as a chemical plant explosion that has nothing to do with terrorists, but nonetheless has large numbers of casualties. Search and rescue is something that I've taken a recent interest in. During the Oklahoma City bombing, 85 to 90%, or sorry, during a standard earthquake, a lot of victims that can be trapped and rescued, it happens within the first 24 hours. After that, the numbers of people that start to be rescued, that can be rescued, goes down. In the United States, the urban search and rescue response teams have times that they're allowed to get off the ground and to a site when they're expected to leave within 4 to 6 hours, and time to travel can take 12 to 18 hours. The urban search and rescue as a specialty really came about as a result of the explosions and came to the forefront during the Oklahoma City bombing when McVeigh blew up the FBI building. The urban search and rescue teams went there and were able to effectuate several rescues. But they are used in other responses as well. There are 28 teams under FEMA, each sponsored by a local agency. We have a team here based out of an area near the San Diego airport, sponsored by the San Diego Fire, and almost every agency in the counties has people that participate. A type 1 heavy team, which includes people that are specialists in medical care, in search and rescue, in structural collapse, heavy equipment operators, heavy truck drivers, has 70 members. And that's going to typically be something that will deploy to a large-scale disaster, completely self-contained team, just like the DMATs. Type 3, which is a smaller team, a little bit more mobile, has 28 members. each member, if you join a USAR team, is going to specialize in either command structure, search and rescue, technical rescue, or the medical care of people that are that need your help. There they are. You can see where they are stationed across the country. There are the most numbers of teams in California. As you can imagine, the earthquake risk here is quite high. And so they place several teams here to respond immediately in the case of a large-scale disastrous earthquake, and then spread on the East Coast and in the areas around, as you can imagine, Washington, D.C., highly populated, dense urban areas that, again, that might need those kinds of responses. You have several teams down in the hurricane belt in Texas, Louisiana, Florida, and then other teams spread around the country so that a response time can be effectuated quickly in the need of a disaster, no matter where it occurs in the country. Some pretty patches for you of the different teams. The 8 balls, Task Force 8. As a result of the disasters, it's not just people that get involved. As a result of this incident, the PETS Evacuation and Transportation Standards Act was passed, and that was a law that was passed because a pet was being taken away from a rescued child that was being evacuated from the New Orleans Superdome during Katrina. The child was screaming, "Snowball, snowball," protested and vomited. This got the attention of Congress people who passed a bipartisan act that now requires FEMA to accommodate pets and service animals in the plans for every kind of disaster, and to make sure that people are with their pets. Because as you can imagine, once people become separated from their pets, not only does it become stressful for the people that are involved and the animals, but it is very unlikely that the people and pet will be reunited in the future. There are 2 big forces at work, external and internal. And we have very little control over external forces such as tornadoes, earthquakes, floods, disasters, illness, and pain. What really matters is the internal force. How do I respond to these disasters? Over that, I have complete control. So how you respond is set up in the framework of the Hospital Incident Command System. And this is based on the Fire Response Command System, which was started by the fire agencies that responded to large forest fires. They found that that form of command and control translated well to the hospital. And so the hospital response is really formulated and copied after that. I'm not going to get into that today. Most of you are probably saying, thank God. But if you're interested in disaster response, you should definitely take a look at that and learn about it so that you can function effectively within an incident command structure. So what is the role for medical personnel in disasters? Things that those of you listening to this webinar can and should be getting involved in is, first off, what's your hospital's plan in the event that you have internal, external disasters? How do you guys do decon? How do you do evacuations? Who's in charge of the hospital's planning? Oftentimes there's a disaster preparedness committee. If you're in a hospital and you want to get involved, that's a great place to participate, because you can have an effect on what kind of responses the hospital comes up with. If you work in a hospital, or even if you work in a first responding agency, you're going to have an assigned role. If not, you should know it and find out what it is, because I guarantee you they will have a role for you. And then know how to evacuate patients from your specialty area in the hospital in the event of a disaster. Where do they go? What do you do? How do you transport patients? For first responders, they all have hazmat plans. What are the hazmat plans for your hospital? And then begin to spend some time thinking about how you might deal with alternate standards of care during a disaster, and how's that going to change what you normally would do in your unit where you'd be providing patient care. What does altered standards of care mean? What does that mean to you? It means that you may not have the use of x-rays, CT, ultrasound, and those things are often used to help guide us when we make life and limb-saving decisions. And rather than focusing entirely on the patient that's right in front of you, in many times, disaster requires you to do the greatest good for the greatest number of people, as opposed to maybe what is the best thing for that one person that is right in front of you. It does require avoiding over and under triaging to operating rooms, to ICUs, ventilator care when the needs exceed the resources. These things, ICS 100, 200, 700, and 800, you can take online, and I believe that they are free in order to understand about the hospital incident command system. I gotta recommend that to you highly. It's not necessarily the most enthralling thing to do, but it really does allow you to understand how systems work in response to the disasters, and then participate. Our residents in our emergency medicine residency program are required to participate in 2 disaster response exercises during the course of the residency. And I would recommend that you at some time at least do one. For those in private practice or who don't have inpatient responsibilities, you may, if your place is open, you're going to need to go to work. Obviously, you take care of your family first. And once your family's needs are taken care of, you get to work and you help, because there will be a need in the case of a disaster. If your office is closed, then what do you do? Well, then this is where it's a good time to go volunteer at a hospital. And if you've done your homework, they're going to already actually know who you are and know what your capabilities are. And it'll make it that much easier for you to participate in delivering care. Get to know who the players are in your community ahead of time, so that it makes your ability to respond and help that much easier. Triage, the whole concept of triage, most of us in emergency type medicine and first responding agencies do know a little bit about triage, in which we triage people to the acute, the immediates, the delayeds, and the minors, and then we see the patients accordingly. There may be situations where if everybody is triaged as an immediate, then nobody is an immediate. And if you're under triaging people, you will have patients die that shouldn't have otherwise died. It's an art. And I'll be honest with you, in my experience, most of the best triage officers are not physicians. They tend to be people who have experience seeing people in the field and making quick judgments. Some nurses are very good at this. Paramedics as well are very good at this. The needs of the many outweigh the needs of the few or the one, and that certainly would apply in the settings of disasters where local resources are truly overwhelmed. So, how can all of you get involved in their specialty? How can you use your special skills to become involved anywhere in the state or in the country? First of all, go sign up for the Emergency System for Advanced Registration of Healthcare Volunteer Healthcare Professionals. California's got a website where you can actually go. They collect information about you, including your contact information, your medical license information, nursing license, paramedic license, what things that you are able to do, what's your specialty, and then they will reach out to you in the case of a disaster to see if you would like to become involved. There's a screenshot of the website. Dave Duncan, it has Gavin Newsom, the current governor, and Dave Duncan, the current EMS Medical Authority director there. And it's pretty simple to do. It's pretty straightforward. Anybody can do it, especially those that don't have a lot of gray hair like I do. Second, you can join the County Medical Reserve Corps. And that link there will also take you to that site. I do believe that these systems were accessed during the recent Imperial County COVID surge, that medical professionals were able to volunteer to go out and assist with the Imperial County's response to the massive numbers of COVID-19 patients that they were seeing that rapidly overwhelmed their ability locally. You can join a DMAT. That's one of the things that I do, where you would deploy to any place in the US, rarely internationally. It's been done a few times, but mostly to national disasters. And the way that that works is you go through a process where you apply on usajobs.gov when a job opening occurs on the team that you want to join. And if you check the DMAT there, you go to the FEMA webpage, they'll list all the DMATs. We have one in San Diego, that's DMAT CA4. And so you find a team that's near you geographically, and then you go to the team meetings that they have. We have a monthly team meeting. You get to know the people, you learn what kind of openings do they have on the team. And then when a job opening comes up, you apply. And then when you become deployed to a disaster, you actually get paid as an intermittent employee of the federal government. You are provided the malpractice insurance that is required in order to operate within that framework. It's not something that you can just do at the time of a disaster. This is stuff you have to do ahead of time. These openings typically come up once a year. We just completed a cycle of hiring, I think within the last month or two, but never too early to get involved. These are the NDMS, which is the National Disaster Medical System, is a partnership of all these agencies, including partners from the VA, from the Department of Defense, and Homeland Security. So what does NDMS consist of? It consists of the response teams, the DMATs and the USARs, the DMORTs, the VMATs, which are the veterinary medical assistance teams. It consists of the medevac system, which is primarily run by the DoD, and then the member hospitals and beds that are available to be used in the event of a disaster. Of interest, there is this thing called the Strategic National Stockpile, in which the government, I believe, has 8 of them. I'm not exactly sure about the number, but there are several of them placed around the country in non-disclosed locations that contain large repositories of antibiotics, vaccines, antidotes to chemical toxins, other medical equipment and supplies that might be needed in the event of a large-scale disaster. And they can deploy that in as little as 12 hours from the time that it is assessed to be needed by the disaster management system. It used to be run by the CDC, and that's now part of the ASPR, which is the Assistant Secretary for Preparedness and Response branch of the government. There's a picture of a couple of them. They come in these easy to load containers. These ones here are set up to go on an aircraft. As you can see, they're in those pre-loaded containerized things with the forklift can just pick them up. They throw them on an aircraft, typically a large Air Force transport aircraft. I know that FedEx and UPS can also transport these in the need to the site of need. So what other types of responses are there? I mentioned them before, the DMATs, which is the medical assistance team, the DMORT, which is the mortuary operations team, the tactical critical care team, which consists of intensive care physicians and surgeons. You have veterinary response teams, and then there's logistics. So say perhaps you have enough medical personnel, but you need the equipment to help take care of your patients. The logistics will deploy to help you obtain the things that you need. And then an incident management team, which is with every disaster that has a federal response, one of these is deployed, and they serve as the brain hub for the response and help to coordinate incoming information about needs assessments, and then they provide the resources to that response. What does a DMAT do? These are the different roles that you might get staged to as a DMAT team: patient triage and treatment site, or you set up a regional evacuation point or patient reception point. Those are really the top 3 that DMATs do. Other things that are needed and that our team has done include hospital staffing relief. Some of the members of the DMATs were used to help decompress the Imperial County during the COVID surge and other places in the country where they'll send medical officers to assist with staffing. Hospital augmentation. So when a hospital is overwhelmed with numbers of patients and the emergency department and facilities become overwhelmed, the DMAT sent to help take care of that load. Sometimes there'll be shelter care, whether it's just standard shelter or for special needs populations such as nursing home evacuees or special needs patients. Medical strike teams. One of the deployments that I got to go on was to the State of the Union address, where there are disaster response teams set up around the Capitol in the case of a terrorist or mass casualty incident. Medical support for other response teams, such as perhaps 9/11 or for the fires, DMATs participated in that, and then some other things there that you see. The deployments that we've had, our first deployment was to the Northridge earthquake in 1994, and the most recent deployment was to the Grand Princess cruise ship that was returning through San Francisco, where they were debarked and tested, and COVID patients were treated and transported away. The deployments that I have been on were the Hurricane Katrina response, and the State of the Union address, and Hurricane Harvey. Those are the three that I've personally been on. The wildfires, some of you who are listening to this webinar may have been involved in those. We did help assist in response to that too. In 2001, the DMAT did set up a triage and medical care area at Ground Zero to take care of the first responders that were working the pile, trying to find anybody that might have been buried. So just to recap, you can respond locally. You can go to join your CalMAT, which is California-based medical assistance team, which is used intentionally to be used only within California. If you want to go to the larger scale federals, you can do the DMATs. If you're into forensics, dentists, medical examiners, even radiology techs, you can join a DMORT. And then if you want to go international, you can hook up with an NGO or other organization that does international relief. The job titles, some of you are wondering, well, is my job available to be done on the team? These are the things that make up a DMAT team. Commander and a deputy commander, they're the ones that are responsible for the command structure. You have an administrative officer who does things like the paperwork and paychecks. You have 3 logs officers and communications officers. Typically, you'll have 2 physicians, 3 PAs or nurse practitioners, 6 to 8 nurses, 4 to 8 paramedics, 1 to 2 RTs, 1 or 2 pharmacists. You may have a lab tech, depending on the disaster. Every team has a safety officer that makes sure that the conditions are safe for the team being deployed. A job title that just recently came back was a psychologist and mental health counselor that for a while had taken those away, much to our chagrin. We're much happier to have them back. And then 6 flex positions, depending on, again, the specific mission that can be flexed up with physicians or nurses or logistics personnel, depending again on the needs of the specific disaster. During the Northridge quake, the first response that they had, many of you who grew up in Southern California probably were here for that. I remember when that happened during my first year of medical school. That caused a lot of damage, and the DMAT responded to a hospital, and they performed hospital relief at Grenada Hills Community Hospital. A lot of water damage made that hospital essentially non-functioning on the top floors. The emergency department did stay open, and the gang worked there. There's a motley crew, including some faces you may recognize. Those of you that are, who know the local community, I can see in that picture Jake Jacoby. I can see Peter Rosen. I can see Michelle Grad. And I'm sure a lot of you all recognize. Maybe some of you on this webinar were there too. They did support at the 9/11, like I mentioned. They rotated every 2 weeks to provide medical care for the guys working the pile. Initially, they were supporting the search and rescue teams, but then as things turned into just recovery, and then as you all know, a lot of the first responders worked that pile till it was done out of a sense of duty to their fallen comrades. DMORTs were there for years, trying to get patients identified so that remains could be returned to their families. They responded to the super typhoon in Guam, which is a U.S. territory there, and provided hospital relief at the Guam Memorial Hospital. This is some of the other works that's been done. You've got some training exercises going on the left, responded to chemical fires, and then just some other scenes of action shots of people delivering medical care. Katrina, that was one of a Category 5 storm that flooded New Orleans, went over the levees there. It was a major hurricane with multiple different types of missions. Over 1 million people were displaced, and the area that was covered by the disaster declaration related to that disaster itself was just about as large as Great Britain. Our DMAT mission at that was to set up a receiving area at the New Orleans airport, where we received all patients that were in the area that were brought to us. to perform triage, and then to set up a regional medical evacuation point from there to other parts of the country, Houston, other cities that were able to take patients who really had nowhere else to go from that area. This is just a schematic of where the whole disaster of the airport was. We were isolated to this area of the airport. It's a great experience to be able to go to a disaster where you truly feel like you made a difference. And in that one, had we not been there, it would have been a major problem for thousands and thousands of people. Patients were brought to us by helicopters that would circulate around the New Orleans area, rescue stranded people, fly them to the airport in all sorts of military helicopters. Again, you can see it's DoD. So you have Chinooks, you have Seahawks, we had Black Hawks. We had every type of rotor asset that you can imagine, bringing patients in a conveyor belt-like fashion to be loaded and escorted from the area to where, if patients were just simply evacuees, they were then sent to an area where they were able to get evacuated. And if they had patient or medical care needs, they were brought to us, the DMAT. It was quite a scene. I don't know that these pictures really show what it was like there, but it was a disaster in every sense of the word. In every sense of the word, we were rapidly overwhelmed when word got out that we were open for business, and that lasted for nearly a week. Perform medical care in little tents that we had set up inside the airport to set up patient care areas. At that one, we actually did a critical area, an intermediate area, and then a walking wounded area. Patients that needed immediate care that we could not provide were transported by air, either by local helicopter EMS agencies to other parts of the country that still had capacity, or by the Air Force and National Guard using what are called CCAT teams, critical care transport teams. We had a pharmacy set up in, of all places, the bar, where we would be able to get, whether you needed a little bit of antibiotic or you needed a little alcohol. I think these taps were empty though, unfortunately. And then you had some bright moments where people, life goes on in the middle of a disaster. And thankfully with us, we had a nurse midwife who was able to assist in developing several children. Here's one that she was able to help deliver in the time of the disaster. And happy but tired mom. And here we have a lot of the patients that were waiting for evacuation onto one of those CCATs so that they could then be transported to hospitals across the country. And this is what we were able to do to stage folks so that they could then be transported out to the aircrafts. As you can see, it's hundreds and hundreds of people being managed by our team and several other teams that were with us at the airport. There's a typical aircraft that might be used. I'm not going to pretend I know what that is, but it looks to me like a C-130, but I'm not 100% sure. Somebody on here probably knows. Where patients were loaded using those military litters into the aircraft and then flown, getting medical care along the way to their points of departure. And then there's a picture of a CCAT team doing their job. Those of you that are interested in that specific type of medicine, in order to do that role, you need to be intensive care, if you're a physician, intensive care or emergency medicine trained with a current experience, or intensive care nurse or RT with current experience to be able to join those teams, which I think are 8-member teams. And the Air National Guard has a CCAT division. I know that the Air Force, if you're a reservist, you can do that. And then now the FEMA and NDMS has started developing CCAT teams of their own to use in time of a disaster. That's what the New Orleans looked like immediately after. And this was what the outside of the airport looked like when word got out that we were receiving patients and that we were a place to come if you needed assistance. That really doesn't show the extent of it, but there were a lot there. And it turned out to be one of the largest medical evacuations ever performed by the United States. The total number of medical evacuees was 2,700, and that's, I don't believe, an accurate number. That probably underestimates it. But the total number of evacuees, nearly 24,000 people evacuated within days of opening that facility. If you want to do international work, you can join a non-governmental organization, 8 organizations. There's lots of them. I would say that some of the more respectable and well-repudiated ones that have the best reputation, the Flying Samaritans, Médecins Sans Frontières, IRT, which is one of our local teams, international relief teams. It's here run by Barry LaForgia, International Medical Corps, as well as Team Rubicon. So those are all very reputable NGOs that respond internationally to disasters. You can go respond to an international disaster, it seems, with almost anyone. I would caution against that. You really want to make sure that you're going with people who know what they're doing, who have a history and a track record of doing things that are more than just glory medicine, where you just fly in and take care of a few people and leave and say you did a great job. That doesn't really help that many people. I went with IRT, sponsored by UCSD. We went to the Haitian earthquake in 2010. That's their Capitol building. Immediately afterwards, this is kind of some of the devastation that we saw just driving to our site, the Port-au-Prince University Hospital. And some of the things that I saw in this one, I wanted to relate this to you to other things that you might expect to see during a disaster, would be that things really are not what you're used to. The patient care is being performed outside. When we got there, the people that had evacuated there had set up little tent cities. They'd moved the beds outside of the buildings into the terraces and the areas outside of the buildings. There was no oxygen capacity. The blood bank that they had that was minimally functional before was completely gone. Radiology didn't really work. They had some rudimentary OR capacity that was being run by some of the NGOs that had already set up there. But that is not what you are typically used to taking care of people. They did have one building that they used as a makeshift emergency department, but every aftershock that would happen, everybody would run out of the building, and then it would be hours before anybody would go back in until it was inspected by a civil engineer. There was no electricity, there was no running water, and there was no flushable sanitation. And in addition to that, the human waste and people that had passed away were everywhere. This is what we called the tent city, which was in the central courtyard of the university hospital, where patients had been set up to be taken care of. And a lot of it there was being done by family members that were assisting the people that were there to help. There was, like I said, no sanitation. And this is one of those things that you don't think about every day, because in the United States, we don't have to think about this. We have people that do that for us. You go to a third world country who has very poor resources and minimal sanitation to begin with, and then you have an earthquake, it's easily overwhelmed. And if you don't get on top of this and deal with this, you're going to end up with more patients to take care of than what has already been produced by the disaster. That was our CT scanner, which, as you can tell, non-functioning out in the street. You make do with what you have. We were able to bring with us a Sonosite portable ultrasound, so that was a tool that we used a fair amount. Mercy, which was one of the U.S. naval ships, was able to come and offload some of the more critical patients that we had. That was part of the DoD's response to the Haitian earthquake. And then other things that you do, most of us are comfortable and used to having medical charts, or even during a disaster, we have disaster tags, and we have charts that we keep with the patients. That doesn't really work in a disaster. And so in this case, what the surgeons who'd been operating all these folks said they do, they write the patient care instructions and the plans and all that on pieces of tape that they stick onto the patient's wound or extremity so that it doesn't get separated from the patient. You put it on a piece of paper, that paper's gone. The patients get moved, the paper gets lost, it doesn't work. That's one thing that I learned during the disasters is you put the stuff that's really important, you stick it right onto the area that it's important for, and it tends to stick around and not get lost as easily. Again, you're going to be taking care of things in areas where you're not used to, and you'll be exposed to stresses. We all got plenty of stress in our daily life, and now you add on top of that a disaster response where you may be exposed to the continued conditions that created the disaster. So whether it's an earthquake, you might get aftershocks. If it's a hurricane, you may get continued flooding. You're going to work long hours with minimal staff, sometimes in the heat. You're not going to always have as much food as you like. For a while, we had to make do with MREs, and we were allowed one MRE per day during that deployment to Haiti. When you respond nationally, it tends to be better in the United States. And then you also have to sometimes work shifts you're maybe not used to. And you get faced with ongoing deaths of patients. One of the things that's very stressful is to lose a patient. Nobody ever feels good about that. And now you put that in a situation where you're doing the best you can, and you know you could do better if it wasn't a disaster, but you just can't, and you lose somebody. That continues, and that becomes stressful as well. I show this not for shock value, but just to show you some of the things that you may get exposed to. That is the morgue at the University Hospital overflowing with patients. And that is something that we had to contend with, and we helped them to help contend with that, which in and of itself is horrific. Aid responders get ill, they get dehydrated. You got to take care of yourself as best as you can. But then you get these moments where you help take care of somebody, and you get some appreciation. And just to see a smile sometimes during all the horrific things that go on during a disaster is really special. So, bottom line, by failing to prepare, you're preparing to fail. Go out, get involved. I hope that I've given you some resources that show you how disaster responses are managed in the United States. What are some of the key roles that you can do as a medical personnel, whether you're a first responder or you work in a hospital, and then ways that you can get involved by getting signed up ahead of time and starting to learn about it, so that when the need comes, you can answer the need, both locally, nationally, and internationally. So I hope that was informative for you. I wrapped up in about 45 minutes. Anything else, questions? Steve, Tom, anybody have anything on the chat?
I got a question for you, Dr. Sloane. From signing up, about how long is the training for the DMAT team once you're selected through the process?
So from the moment that if you actually get hired to fill the position, what will happen is that you will start going through some online modules, but you are deployable as soon as you complete the online training modules. And then after that, the training is with drills and responses. You can sign up and be deployed within days, if that's how it works for you, if that's just how it happens.
Wow. And the online, is that just the FEMA modules?
Now, the online training that is for the DMATs is specific to NDMS, and they come out, and a lot of it is things that are very much redundant to the things that you might do in a hospital or pre-hospital setting, such as bloodborne pathogen training, some computer things that they make you do. You do have to have ICS training, which you do online, and there's some other modules depending on the type of mission. So for COVID, we all had to do some COVID modules to learn about how to safely take care of those kinds of patients in the framework of a disaster response. And then as somebody asked, I see here, are DMATs selected in September? I believe that is typically done on a rotating as needed basis and according to the needs of the federal government and what their budgets are. It is frustrating because we had a significant need for a long time, and because the budgetary constraints were there, the NDMS had a hiring freeze, and so we were losing members from our team faster than we could replace them. And so I think that this most recent one just happened to be when we were able to do it. So I don't believe that there's a specific time. If you're interested, the best thing is to do is reach out to the team you're interested in joining. You are welcome to attend the team meetings. And I know that CA4 is very open to having people who are interested attend team meetings to learn what it's all about and become involved. And then they will help you, shepherd you through the process. The USAR teams, they are not online right now. I believe that the hiring closed for this current round of hiring, and especially that they don't have a new budget for the next federal year. It's going to be a little bit of time probably before they do open up some other hiring. So if you're interested, link up with the team that you want to join, and they will tell you exactly what you need to do to get involved and to get hired. And if you meet the needs of the job and they need you, they will help get you through the process.
We have a question from Danielle asking what the commitment is for DMAT.
So the commitment for DMAT is that our current team commitment for the CA4 is that we request that you be available for 2 of our 3 on-call months. And what does that mean? So DMAT CA4 is first up for call for disasters 3 months out of the year. And so what you have to be available to be called up for 2 of those out of the 3. And what typically happens, most of us don't leave the whole month off. So what we do is we just maybe schedule ourselves a little bit lighter in the call months so that in the case of a deployment, it's much easier for us to reach out to our colleagues and get coverage for our shifts. That's what I do as a physician. I know that a lot of the nurses, that they have other processes through which they get their work covered. And the good thing is that there's a federal law, USERRA, that allows you to deploy to a federal disaster without facing any negative ramifications at work. Your work cannot punish you because you took 2 weeks to go to a disaster response, as long as you work with them to help make sure that your things get covered.
We have one other question. What type of work do paramedics and EMTs typically do on the DMAT?
So it's going to be paramedic and EMT stuff. So if it is, you're going to be assisting with care for medical patients, you're going to be doing some triage. A lot of the times our paramedics help us out with our triage with a nurse. They'll be doing strike teams where they go out and do mobile assessments where, say, we were set up at Harvey, but they wanted us to go check out. We'd heard that there was a lot of patients at a convention center. So we sent out a doc with a couple of paramedics to go to that convention center and assess the need and take care of anything that they needed immediate treatment, but then also scout it out so that the incident management team could know whether to send more resources to that area. So it's whatever your job you do at home. A lot of times it's very similar to what you're going to be doing in the DMAT, with the exception of transport. You won't be doing any transportation of patients as part of the DMAT.
Excellent. Well, I think that that wraps us up for today. Thank you so much, Dr. Sloane. That was a lot of information, a lot of really good information. So I encourage all of you to go out and check that out if you're interested. And what was that website you referred to at California one more time?
The healthcare let me pull it up. I'll read it exactly to you, just so I don't screw it up, which I could easily do. Here it is. Healthcare volunteers, one word, healthcarevolunteers.ca.gov.
Perfect. Just for everybody to know and to finish John's question, each of these webinars is going to be available online. You're going to be able to view them. We're just working through the logistics of how to get them uploaded to a YouTube page. So please stay tuned to the SoCal ECC Facebook page, and we'll be putting out more information regarding that. Again, the CEs will probably go out for this webinar in a week. For last Friday's webinar, they should go out this Saturday, or this Saturday coming up. So that should do it. And I think that's going to wrap us up for today. So thank you very much, Dr. Sloane, and thank you everybody for attending. We hope you enjoyed this webinar series, and hopefully we can do it in person next year.